Today we're going to talk about how to go beyond the DSM to have a more balanced conceptualization of mental health and behavior. For those of you that are unfamiliar with the DSM, it is really the gold standard in diagnostic evaluation for mental health and disorders. It's the publication by the American Psychiatric Association that really is the standard for the mental illness guide. Two major themes that we want to talk about today, which is that mental illness disorders are socially constructed. They come from our evaluations of what's normal and abnormal. They're based on opinions and values, mostly the opinions of clinicians, and have incredibly strong negative connotations, which has huge implications for the type of mental health that individuals will ultimately seek. And what I think will be really interesting in the second half of the lecture today is that the information that the clinicians get from the DSM doesn't necessarily aid them in the selection of the right type of treatment. Okay, so part of what we've talked about throughout this entire book, throughout this entire chapter, is that really for the latter half of the 20th century, the mental health focus has been primarily on the negative aspects of human behavior, with really very little attention paid to the positive aspects. A huge focus on symptomology and dysfunction, what's not working in a person's life, and obviously within that framework, each diagnosis represents sort of this cluster of symptoms that a clinician would observe, and is really those symptoms are associated with some sort of significant impairment or distress. There's probably a couple of reasons, maybe a few reasons, why work on optimal health functioning is really lacked behind mental illness. There's a thought that the attainment of positive mental health is very passive, though as we've seen throughout this class, it's very active. The remediation of mental illness demands many more resources, and there's probably a theoretical opinion that the alleviation of suffering warrants greater attention than the promotion of health. And I think that really when we look at what we're going to talk about today, that maybe some of that is true, and maybe some of that is assumptions that doesn't have strong validation. There's really some exceedingly important assumptions when you think about the clinician-patient interaction. One is that in this interaction, the client will actually present the symptoms that are characteristic of the particular mental disorder that they may actually possess, and that those symptoms will cluster in a way that can be categorized and labeled in some sort of way that's going to help us understand. So part of what I think is really problematic is that because of the strong emphasis on the negative aspects of human behavior, the conversation that can happen in a clinician's office can be focused on questions that are really designed to elicit certain types of symptoms, and so clinicians are often guilty, really because of this sort of training, to sort of expect to observe some sort of dysfunctional behavior and to try and be able to classify it. Most of what I think is going to be talked about through the first half of this is that some of these behaviors that may seem like they're mental disorders really could be results of either environmentally or situationally determined factors. So one of the big recommendations that we'll talk about is that these syndromes, we should take into account current situational and environmental factors, and not just assume that these are part of an individual's makeup. So in this case, environmental influences on behavior really have not been adequately addressed by DSM-4, and part of what we'll see if you look back at sort of classical theories of social psychology are things like the fundamental attribution error, which is the tendency to look at a situation and use ignore situational factors and explain a person's behavior and assume that those are mostly dispositional. And so what we have really seen is that by focusing on sort of the negative aspect, ignoring the positive aspect, ignoring sort of environmental factors that might be producing certain types of behaviors, making sort of fundamental attribution errors, is that there becomes this huge focus on the negative. And in many ways, if we're going to judge behavior with only a small amount of information, when a behavior is negative, it really stands out more than when it's positive. And this has occurred at the expense of looking at the strengths of individuals, again, looking at sort of the environmental deficits and the resources that they have, and coming up with a treatment plan that ultimately will assist people in their pursuit of optimal human functioning. So today what we're really going to talk about are some of the current limitations in the DSM framework, and try and talk about some alternative means for conceptualizing behavior and ultimately treatment. One of the things that I want to sort of talk about are that there are, I think, three fundamental assumptions about mental illnesses that, to a certain degree, don't really have a strong basis if you look at the research. And so the first major assumption is that mental illnesses are sort of facts that can be classified in discrete categories and ultimately observed. And part of the problem here is that the assumption is that mental illness sort of reflects these facts that about people that are actually struggling in the world, and that the sort of complaints and the disturbances that come out in the reports are sort of based on some sort of real set of a sort of cluster of symptoms. But there's a huge number of problems with this assumption. So first, if you look at certain factor analyses, which are analytic procedures that are used to look at the structure of personality questionnaires, when they examine individuals who have, quote, normal or a lack of symptomology, and individuals who have personality disorders, the personality structures look remarkably similar. The personality in these two groups are really much more alike than they are different. Also, if you look at trying to discretely classify normal and abnormal emotional experiences, this is actually exceptionally difficult in that normal and abnormal emotional experiences really are not able to be discretely classified. And so if you begin to think about the ability to sort of look at these as facts, it's unlikely to be true. So what we would suggest as sort of an alternative is that clinicians should be sort of aware of different types of constructions of behavior, and try and entertain as many alternative possibilities as they can. Okay, assumption number two is that these labels, these diagnoses, produce a certain amount of understanding that sort of promotes sort of what's going on in a person's life. Again, there's a problem with that assumption because the DSM really only focuses on the negative aspect of a person's life, so it's really hard to sort of understand what's going on in a person's life if you don't understand all the contextual factors. And again, because of the diagnostic system being preoccupied with the negative categories, it really sort of undermines the likelihood that the clinician's going to sort of attempt to holistically understand the client. So the categorization only describes what's wrong in a person's life, and the degree to which a clinician attempts to understand the client fully is really minimized if you think sort of about these diagnostic labels. There's also some problems in actually looking at diagnostic procedures in general. McDermott found that there was very little disagreement, really no better than chance, when looking at 72 practicing psychologists. There's significant problems with using sort of a classification system, that's advocated by the DSM. So, mental health professionals can become preoccupied with forcing individuals into negative categories. There's going to these categories will really limit our understanding of the person in a comprehensive manner. And then what we'll really see here is that these negative labels create these huge stereotypic expectations. That people are much more different than they are similar, which is not true, and there's a huge huge sort of cost to an individual if the diagnosis that they may or may not possess actually becomes common knowledge.